So I'll try my best to be very quick. Presenting at 4:30 is a bit difficult. So try to focus on septic arthritis, gout, not think about traffic and what's for dinner. So acute monoarthritis. So just to have some revision from medical school, so that when we are saying acute, so I mean in the less than 2 weeks. Normally patients with monoarthritis present in few days. Monoarthritis, I mean one joint to be affected with hot swollen joint. So there are very variable causes of monoarthritis, but what I'm focusing in this presentation is basically septic arthritis and gout. The most important one to be excluded and diagnosis is septic arthritis, crystal arthropathies, which include both gout and pseudogout, and reactive arthritis. It might be monoarticular presentation of polyarticular conditions, like, for example, rheumatoid arthritis to present with one joint affected, but that's not a common condition, or it might be a mechanical cause. So let's try to go to the septic arthritis. And so if you define septic arthritis, so basically this is pyogenic infection of the joint. It is a medical emergency. Therefore, prompt diagnosis and appropriate treatment is very important to prevent irreversible damage in the joint. The most common cause is Staphylococcus aureus, and it's not a common condition. The incidence of that is about 6 to 10 per 100,000. But if you look at the patients with inflammatory condition, that incidence increase significantly to up to 100 patients. So the risk factor, which kind of patients you look in septic arthritis, it might happen in normal people, but is more common in those patients who are already having predisposing joint problems, like, for example, having inflammatory conditions, rheumatoid arthritis, or severe osteoarthritis in the knee joint, or they are on immunosuppressive agents, including DMARD or biologics that we talked about earlier, patients with immunosuppressive conditions, diabetes or chemotherapy, intravenous drug users, or even alcoholic. If we talk about the signs and symptoms, obviously, is if you have a patient with short history of hot swollen joint with limitation of movement and tenderness, this is septic arthritis until it proves otherwise. There are other symptoms which is coming with septic arthritis, like fever, but absence of fever is not excluding that condition. So that's been fainted because we thought this kind of investigation, it can be done by the secondary care. But I'm aware that some GPs also doing the synovial fluid aspiration, and even they do injections. So if you are doing the aspiration, this little is related to you. So the warfarin and apixaban, which is very often used among the patients with anticoagulant patients, is not contraindication of aspiration. Try to do your aspiration, and the specimen should be sent to lab as soon as possible. So if you do the aspiration in the morning, sending the specimen in the afternoon, that's not good. You send the patient for basically cultural sensitivity, and in addition to that is the polarized microscopy. This is to exclude crystal arthropathies. Meanwhile, the negative gram stain and culture is not excluding septic arthritis. Prosthetic joint, if the patient has already had knee replacement or ankle replacement or whatever the joint, is better to be dealt with the orthopedics. Obviously, when we see the patient, I'm sure this is the management plan of septic arthritis. Some of the investigation you can do, some of them should be done by the secondary care. The blood culture can be done by the secondary care, but you can arrange for the patients for at least basic blood tests like FBC to look at the white cell count, inflammatory markers, ESR and CRP. They are very good picture for showing the inflammation. And also serum urate, sometimes we do it with, but it's not very helpful, especially due to in cases of acute gout. actually the urate might be low instead of high. We do urea and electrolyte and LFT just a baseline. It might affect the choice of the antibiotics. So imaging is, as a baseline, X-ray can be done in the secondary care, but it's not very helpful. We don't diagnose septic arthritis on the basis of X-rays, because if the septic arthritis is not treated for maybe a few weeks, then it might cause some changes in the X-ray. MRI is more sensitive for conditions if you are thinking about osteomyelitis. So the treatment of septic arthritis, obviously, it comes from the name, it's infection, so it's antibiotics. There is no evidence base how much do you use IV and how much do you use oral, but conventionally what we are using is 2 weeks IV antibiotics and followed by 4 weeks of oral antibiotics. So the patient might be admitted in hospital for a few days, and then sometime we just refer the patient to primary care to continue with the IV antibiotics. So as I mentioned, this is when you see the patient and when you do the history and examination and considering the risk factor of the patients. So you can, if you diagnosed the patient with septic arthritis, you did the required blood test, it's better to refer the patient to either rheumatology or orthopedics. We had this discussion, so normally the patient might need a washout, so the first line is to orthopedics. But if the patient has like inflammatory arthritis, they are on DMARD or biologic agents, it's better to be referred to us to rheumatology. So some useful point about acute monoarthritis. The commonest hot swollen joint that you can see in the primary care is the first MTP, which can be diagnosed as gout as on the clinical suspicion. If you can aspirate the joint, it is better to confirm your diagnosis of gout. If there is doubt about septic arthritis, don't use intra-articular steroid injection. If you aspirate a cloudy fluid, it's better to send the patient and the fluid to hospital as soon as you can. For rheumatology patients, as I said, if they are on DMARD or biologics, there is no evidence to stop the DMARD during the septic arthritis. I see many patients that the DMARD has been stopped even due to simple infection, but there is no evidence to stop the DMARD. But for biologic, the BSR, which is our guidelines, recommend to stop anti-TNF medication for at least 1 year following the infection. So as I mentioned, following septic arthritis, patients should be admitted to hospital, refer the patient to orthopedic urgently, especially those who are having prosthetic joints, and refer patient to rheumatology urgently, those on DMARD or other biologic agents. So this is just to scan this slide quickly, what we are doing in the secondary care. Basically, we see the patient, we do the required investigations, x-rays, blood cultures, and then we aspirate the joint up to dryness. And sometimes we also let the orthopedics know if they need to do a washout, and we put the patient on antibiotics. So acute gout. This is a very common condition, and you can see in the primary care. So when we say what's acute gout, so basically it's inflammatory arthritis which is caused by deposition of a kind of crystal which is monosodium urate, and either inside the joint or even in the soft tissue. And the risk factors, there are lots of risk factors as hypertension, overweight, people on diuretics like loop diuretics or thiazide, and also sometimes when we are saying the precipitants of attack, we do have patients who never had gout, but they admitted in hospital, for example, for heart failure or MI, and they have been put on diuretics, and they will have the first attack of gout in hospital. Or sometimes due to dehydration. Some patients get attacks of gout just after like exercises or some simple illnesses. So anything which is like reducing the immunity. Could you see this slide? Right, okay, because I can't see it. Right. So as a treatment of a gout, I'm sure you are aware of there are 3 medications which normally we use in acute gout. So when you excluded septic arthritis, what medication we use? Sometimes we also are having difficulties to choose which one of them. So the first line is NSAID if it is not contraindicated. I'm sure all of you knows about the contraindications of NSAID, like heart failure or renal impairment or history of peptic ulcer or gastric ulcer. So the NSAID, I'm aware that indomethacin was used before, but nowadays it's rarely used indomethacin. The simplest or the safest is naproxen, which we use under the cover of PPI. The patients normally respond to maybe 1 to 2 weeks. If then they don't respond or the NSAID is contraindicated, the second line is colchicine, which you use 500 microgram BD to DDS. The problem with colchicine is, as you are aware, is diarrhea and also slow response to the colchicine. Normally, NSAID will be effective in about 4 to 5 hours. However, colchicine, it takes about 18 to 24 hours. So the third line is the corticosteroid, prednisolone, which is very effective, especially in those patients who you can't use NSAID and they are not tolerating colchicine. We normally use oral steroid 15 to 20 milligram. Intraarticular steroid is also very effective. You can use it for the oral one for about 1 to 2 weeks. And the intraarticular one is also very effective, but you have to make sure that that's gout. Sometimes we use IV methylpred, which is very rare, especially if the patient presented with multiple joint affected gout. So, and this is if the patient is improved and resolved. If the patient gets other attacks of gout, the BSR guidelines, which is the British Society of Rheumatology, recommend that the patient needs to be to have at least 2 attacks of gout in a year to put the patient on uric acid lowering medications. As you know, the first line is allopurinol. There are different approaches. I saw many people starting with allopurinol with 300 milligram. But allopurinol is one of the medication who has many side effects, rashes, allergies, and things like that. So the guidelines is recommending to start with 100 milligram. And obviously you have the uric acid, and make sure that during you start uric acid lowering medication at least 2 weeks after the acute attack of gout. So the patient had attacks, you gave steroid or colchicine or NSAID, wait 2 to 3 weeks after, and then you do another baseline uric acid and start your allopurinol. You see the patient 2 to 3 weeks after, and then try to titrate the dose of allopurinol according to the level of uric acid. As mentioned in the quiz, normally our guidelines try to the uric acid should be below 300. You can increase allopurinol to 900 milligram, but hardly patient tolerate that. You might get rashes or even derangement of urea and electrolyte. If you have difficulties, then you have to think about, obviously, other medication, which are not many. I'm going to talk about it. So that's the NSAID that we talked about it. Colchicine and oral steroid, intraarticular steroid, and IV steroid. I should have clicked before. So as I said, should be started in 2 weeks after the acute attack. And please don't stop allopurinol during acute attacks of gout. And this is the level of the uric acid, which the target is below 300. the medication which are used for as a uric acid lowering medication, as I said, there are not many. Nowadays we use allopurinol. There is febuxostat, which is the same mechanism as allopurinol, is a uricostatic, and we also have uric agent, which is benzbromron, is available. We can get it for our patients. And uricolytic agents, which is very, very rarely used, which normally used for patients like to prevent tumor lysis syndromes and things like that. So I'll just, if the next slide maybe, this medication, sulfenparazone, used to be available, but now this is withdrawn from the market because of the side effects. So this is a very simple slide. If we talk about uricostatic agent, as I said, allopurinol, febuxostat. So normally we use febuxostat if the patient is intolerant to allopurinol and is more effective, and the dose is 80 to 120 milligram. And is sometimes it can be used in the mild to moderate patients with mild to moderate renal insufficiency. The uric agent, as I said, is benzbromron. If the patient, for example, cannot tolerate the full dose of allopurinol, or if the patient still get attacks of gout in spite of febuxostat or allopurinol, is a different mechanism, so you can combine it. Uricolytic agent, that's the one which is, I said, is very rarely used. Like there is a medication called rasburicase. So basically, dissolving the uric acid is infusion. The patient needs to be hospitalized, and after a few days, the uric acid is going to be high again. Well, only one patient which I'm aware of, he had it in Barnsley, but after a while, this uric acid came back to the same. So basically, in primary care, you have to focus on allopurinol, febuxostat. I'm not sure if benzbromron is available or not. So these are some guidelines. I'm sure you are more expert than me with how to advise patients on gout. So because of the limited time, I'm going to skip that. So just a few cases, very simple cases. I'm just telling you straight away without any voting. So this 75-year-old overweight admitted with ischemic heart disease, heart failure, on diuretics, and he developed painful ankle joint while he was in hospital. He has been put on antibiotics, I presume because of the fear of septic arthritis, and he was not responding. So the diagnosis of this condition is very clear. The patient have acute hot swollen joint, and he has heart failure. He has been put on diuretics, and it was diagnosed as acute gout. The intervention, we didn't give the patient NSAID because of the history of the ischemic heart disease and heart failure. So the second line has been tried, which was the colchicine. The patient could not tolerate it. He was already having cardiovascular problem, and he didn't want to be in toilet most of the time. So the third one has been used, which was the steroid basically, and he did have very good response. A week later, he had another attack of gout, and by the way, during that time, obviously, you have acute swollen joints, so you have to do aspiration, and it was dried up. The second attack was another attack of gout. Intervention is very similar. We did aspiration. This time, we got some fluid, and we know that this is gout, so we gave intra-articular injection of steroid, and the plan, obviously, a few weeks later, the patient should be on allopurinol. He already had 2 attacks in 1 week. Another case, this patient is I saw as a new patient, 80-year-old male referred from primary care with pain in multiple joints. Further history taken from him, gets attack of severe pain in ankle joints, frequent attacks. He is hypertensive on furosemide, and on examination, nodular bony swelling across the PIP and DIP joints, multiple tophi in hands. This is the hands, and no synovitis. Hand X-ray shows erosive changes. The blood shows relatively high inflammatory markers with ESR of 35, CRP 28. Ureate is more than 500. This is a crystal clear acute case of gout. The treatment, obviously, we put the patient off on allopurinol. Does that patient needs a referral? I don't think so. This patient can be treated in the primary care. This is the last case. 63-year-old male, a known case of chronic tophaceous gout arthritis, multiple joint synovitis, uric acid more than 500, history of intolerance to allopurinol. So the acute management, you try one of the 3 medications that we talked about. Then the preventive measure, alternative to allopurinol, we go for, anyone? Febuxostat. The patient still had high uric acid and further attacks of gout. So basically, in spite of 120 milligram of febuxostat, for some reason we can't give more than 120, which is 1.5 tablet. So the next step is to give benzbromaron, which we can basically combine the medication. Sometimes this kind of patient, when they come in spite of their treatment, we admit them for 1 or 2 days for pulses of methylpred. The problem with these patients, they have other comorbidities. Their urea electrolyte is always deranged, the LFT is always deranged, so sometimes we cannot go to the maximum dose of these medications. Other medications with weak uric effect. So it's not very, they are not very strong, but it has been shown that there are some other medication that you can use for other conditions. For example, fenofibrate or atorvastatin or vitamin C or losartan. If the patient has hypertensive, you can give this medication which has very weak uric agent. Is better than nothing, just to have a support of the uric acid lowering medication that you are already put the patient on. Thank you.
Thank you very much.